Welcome, everyone, to the Capacity Research Center's seminar today. Thank you for joining us, and I know it's going to be a very interesting presentation from Dr. Ingrid Handlovsky and Dr. Allie Slemon, both of who are currently faculty members at the University of Victoria. My name is Patricia Tate, and I'm the Research Program Manager at Capacity. Before I turn the Zoom over to Ingrid and Allie to introduce themselves, I want to acknowledge that the Capacity Research Center is situated on the traditional, ancestral, and unceded territory of the Musqueam peoples, and that we also conduct our research across the unceded territories of the Squamish and the Tsleil-Waututh peoples. At Capacity, we engage with a diverse network of partners and organizations across Canada, and we acknowledge and thank the traditional owners and caretakers of the lands upon which we carry out this shared work. We're grateful for this opportunity to form and strengthen our relationships on these lands. And I also invite any of you who would like to acknowledge the lands on which you're joining from today to please feel free to share that in the chat. Please also note that the session is being recorded and will be available on the Capacity website within a week or two, probably. And after the presentation, there's going to be lots of times for questions, and I'm going to do my best to monitor the questions in the chat and online. And if I miss one, please feel free to let me know. And now I'll turn it over to Ingrid and Allie.
Well, hello, everyone. Thank you so much for that thoughtful introduction, Patricia, and for having us here today, for making the space for us to have the opportunity to talk about this project that we're very, very excited about. My name is Ingrid Handlovsky, and I can share that I'm coming to you from the unceded territory of the Lekwungen-speaking people. I am a very grateful, uninvited, second-generation white settler of Slavic descent, and deeply committed to processes of reconciliation. I am also an assistant professor at the University of Victoria. I happened to do my PhD at the University of British Columbia. Nice to see a couple of familiar faces here, under the wise guidance of Vicky Bungie, who is the reason we are all here today. So very grateful for that experience. And I am undoubtedly sure that mentorship is what in many ways brought Allie and I together, that I have the honor and privilege of working very closely with Allie, and was told multiple times throughout my PhD, you really need to meet Allie Slemon. Do you know Allie Slemon? And didn't happen during our PhD, but lo and behold, here we are today. So very excited to have a bit of a conversation with you folks, and I'm going to pass it over to Allie.
Wonderful. Thanks so much, Ingrid. And thank you, Patricia, for such a lovely introduction. I am Allie Slemon. I use she, they pronouns. I'm also an assistant professor at the School of Nursing at UVic, where I am delighted to work with Ingrid and so many wonderful colleagues, though we maintain very close connections back to UBC because we have the pleasure of working with so many of you who are here today and some who are not. So that's kind of our home institution, and we always value the opportunity to come back and engage with all of you who are still situated there. So thank you, Ingrid, for situating us on Lekwungen territory. The work we do also spans the territories of the Saanich, the Songhees, and the Esquimalt peoples. So we cannot wait to tell you a little bit about this work that is unfolding. Both of us, Ingrid and I, do work that looks at remediating healthcare inequities and promoting the health and well-being of 2SLGBTQIA folks, and looking in an even broader paradigm of enhancing social justice and equity for people who experience many intersecting forms of structural inequities. And so this is one piece of that big puzzle. And yeah, we're just delighted to share some of this ongoing work with you. So I will pass it over to Ingrid, get my screen share set up, and we will take it away.
All right, so many thanks to you, Allie, for taking on the responsibility of the slides as we move through this. So as the title suggests, we're going to be talking a little bit about a 2SLGBTQIA+ liaison nurse role that we have had the honor and privilege of developing into a project And so, as the title again suggests, we're going to be talking a little bit about some of the key insights from what we have positioned as a feasibility study. So, I'm going to share a little bit about the history of the role, because as a nurse, it is so exciting that a nurse is the reason that this role exists. And I believe everybody that is present here today is aware of how challenging it is to advocate, not only to advocate for a role, but to be successful in implementing a novel role. So this role is the product of the time, intention, and efforts of a nurse by the name of Emily Wyatt, who was working at the Royal Jubilee Hospital in Victoria, and as an emergency room nurse, was doing a lot of advocacy, liaising, and support work for the 2SLGBTQIA+ community in terms of supporting people who were coming into the hospital. As we know, hospitals are not often particularly comfortable environments for people who have experienced structural and interpersonal discrimination and various forms of inequities. So Emily really took it upon herself as a community member and as a nurse. So we know our discipline is rooted in this idea of social justice, which can be taken up in a variety of ways. So different conversation for a different time. But the intersection of those things was so instrumental to this role, because Emily, being deeply committed to her community and to her nursing work, was doing a lot of this advocacy embedded within her ER role, and recognized the need for this role to exist as its own distinct entity. And so began doing some very grassroots mobilizing and advertising and talking about the need for what was initially termed a queer nurse, but then had some conversations with the folks in the DEI department at Island Health to say, listen, there's been a lot of concern and a lot of complaints that have been filed from people who have not really had great experiences here within the hospital setting. I'm doing a lot of work embedded within my own role to support folks who are really experiencing a number of barriers when they're within this environment. I really believe that we need a role. So wrote a briefing note to advocate for a specific role for the community, and was really supported by the folks at DEI. And very logistically, the manager within the ER said, all right, let's just get really creative and really tactical. We always have an empty ER line. Let's try this out. We'll position it as a pilot. We can take an empty ER line, put in this new role, see how it goes. And that is literally how this happened. So it happened very quickly, which is wonderful, but also very challenging, because we know there are a lot of logistical pieces that have to be very clearly laid out when we have a new role that's put into place. So it meant kind of having to backtrack a little bit in terms of now thinking about, well, what is this role? Like, how do we define it? Because we ultimately would like to see it implemented in other settings. So getting really clear about what it is that Emily is doing and the services that are provided, the needs that are being met, is really, really important. So Emily approached Allie to say, hey, I am not a researcher, but I'm involved in this new role because Emily's so humble. It's like literally spearheaded this role. And I would really like to get some researchers involved so that we can collect some data about what it is that I'm doing and how people are being helped. And through this, I was approached by Allie. And so we sat down and really thought about what is it that we need to understand about what Emily is doing, because we anecdotally know it's really powerful and really important, but how do we develop a research project around this that's going to explicate the power of this role? So really what we did was design what we call a feasibility study so that we could really explore this role within the setting of Island Health. And with this broader vision of knowing that we would want to see this role scaled up and implemented in other health authorities, other settings across British Columbia. So really what the feasibility study constitutes is Emily being very gracious and taking note of key activities that she is doing throughout a day in her work. And so that's captured through daily logs, which offer really pertinent information about who is coming in. So just demographic information about people that are receiving support, what kind of supports is Emily providing? And then the observations have been really valuable to just understand more about the environment within which this role is unfolding. So we've really been attuned to what we call context and nuance. So what is it about this role that matters for people? And how do we capture that through observing these dynamics between Emily and people who are seeking care? And then how is this actually happening within this broader structure of this health setting where Emily is situated? We have also collected some client case studies. So really specific information about what we position as particularly powerful exemplars of people who have received really instrumental support through engaging with Emily.
Thanks so much, Ingrid. So now my wonderful piece of this is that I get to share some of this mixed methods data that we're collecting within the feasibility study. It is ongoing, so we really are providing a kind of midpoint snapshot, but we truly feel that these preliminary findings are so powerful in speaking to what Emily in this role is doing, how it is supporting people, and the immense potential for this role beyond across BC health authorities, and then we envision potentially across Canada. To our knowledge, this is among the first of its kind globally. It's certainly the first of its kind in Canada that we've been able to identify. We're doing a scoping review to that effect, so we're feeling more and more confident in asserting that statement, but we really value the opportunity to just share some of this with you today, even though it is ongoing, because of just the incredible picture that this data paints of the work that is happening under this 2SLGBTQIA liaison nurse role. So as you can see, very much ongoing. We have 37 daily logs completed to date, but Emily is still collecting data throughout her daily work. So this will go up and we'll consider to have continue to have even more nuanced insights. In these 37 days, this captures 91 clients. For the most part, I will say Emily sees more upwards of the 4 to 5 clients per day, but you'll see later in the presentation why sometimes she sees 0 or 1 clients per day. Interestingly, though there were 91 client encounters, there were 28 unique clients. And so there'll be some kind of nuances as we continue to move through the data about how really intensive and powerful the relational and sustained aspect of this engagement is for clients. Who are the clients? This is one of the biggest questions that we always get asked is, what does the liaison nurse do and who does the liaison nurse see? So we were not shocked, but we were very intrigued to see that the vast majority of clients who the liaison nurse sees are trans or non-binary. So 78%, over 3/4. So really this speaks to the need, I think, and the great extent of inequities and discrimination that trans and non-binary people experience within healthcare settings, and how much trans and non-binary clients are reaching out for this support, and how necessary it is that anybody who might be in a 2SLGBTQIA liaison nurse role really has this connection and competency in working with the trans and non-binary community, because this is so much a part of the role. Notably, also, nearly a third of clients who the liaison nurse sees are Indigenous. And so it's so important to think about what it really means to serve Two-Spirit and or Indigenous clients, and how we can continue to build that capacity. A really important part of how this role was developed is that it was so greatly inspired by Indigenous peer navigators and Indigenous liaisons. And so how do we continue to build this bridge between the amazing work that Indigenous liaisons have been doing for a number of years now, and this role, which also encompasses the Two-Spirit and Indigenous community. And so we've been having some wonderful conversations with our colleagues, many of whom are UBC graduates, to figure out how to further align these amazing programs that are working with equity-owned groups in the healthcare system. So lots of exciting work here based on the data that we're seeing. Why do people who see the liaison nurse, why are they seeking care? We were very surprised to see the magnitude of this chart. This is among unique clients, leaning really heavily toward people who have sought care for mental health reasons. So this is really showing us that right now, where the liaison nurse is situated, there's a lot of work within the mental health inpatient units, and some of this is in emergency settings as well. Though mental health is certainly not the only reason, we're also seeing exacerbations of chronic conditions, why people are in hospital, acute illness and injury, sometimes surgical intervention, and interestingly, fewer people who are receiving gender affirming care. So still a really important part of the role, but maybe not with the same magnitude that we might have thought, which I would love to think is because gender affirming care is already offered in such a safe and affirming way. May not be the case, but certainly I think there's always room for growth across all of these areas. But we were really intrigued by this magnitude of mental health support that the liaison nurse is seeking, which may be a product of the fact that people often have long stays when they're in inpatient mental health units. We also thought it was really notable that leaning into this mental health piece, that so 54% of unique clients that Emily saw had sought care for mental health reasons, but nearly a quarter of the liaison nurses client encounters were among this group. So this kind of speaks to that point, is not only is Emily seeing a lot of people unique clients who are there for mental health reasons, but when she does engage with people who are there for mental health reasons, it's that really sustained and ongoing engagement, such that she's seeing them many times across many different days and really having that relational connection. We also captured in the daily logs what kind of support Emily is providing to clients, or in what ways she's engaging with clients, because this really is that other question, is what does liaison nurse do? And so we can say client care or some kind of umbrella term, but that really doesn't get at the kind of nuances and the extent of that support that the liaison nurse provides. So we wanted to, in this at least quantitative way, and we'll speak to the observations in a minute, but get at what is it that is happening in these client encounters. So we collectively with Emily and the other kind of team members at Island Health develop these different sort of categories to try to tease out support. And it is a bit of a checkbox, and we know it's problematic sometimes when nursing work is distilled into a checkbox, but with observations, we're trying to really capture that big picture of what does this role look like, given that it is a quite new role, and we want to know what the role entails. Over half of the liaison nurses' activities with clients are dedicated to this really broad idea of being present. This is such an important and intriguing term for what nurses do. And there's so many of us nurses in the room. I think we maybe already have a sense, or something comes to mind when we hear that term. But what's really interesting, and that Ingrid will show in a minute, is that there's so much in that. It's relational engagement. Often there's assessments or inquiry that are happening kind of via that relational engagement. But this idea is so intriguing, we're actually writing a grant to go explore what it really is that this idea of being present means. So stay tuned. Other things that are encompassed within Emily's work with clients is discharge planning, care planning, and also because Emily is a nurse and is also an emergency trained nurse, right now that looks like sometimes medication review and or medication administration, looking at lab work, case consultation, a more kind of quote unquote clinical side of the role. Sometimes engaging in procedures, so whether that's accessing PICC lines or kind of more complex medical procedures. And then a big piece is healthcare provider advocacy. So this is specific to a client. So not kind of an education session, but around one client who the liaison nurse is engaging with, undertaking specific kind of advocacy actions that are moving ahead care for this person. So that can be quite explicit, or sometimes through the stories we've heard, a little more kind of implicit or kind of under the surface. So Emily tells a story, for example, of just simply arriving at a nursing station, going forth and meeting with a client, then coming back to the nursing station and using that person, that client's pronouns. And immediately everyone at the nursing station had a switch and started using the client's pronouns. So this wasn't something that Emily, stood up there and gave a big lecture about pronouns, but just through kind of leading by example, was able to change the kind of culture and actions of people who were on shift that day, which we hope has implications for how that client care proceeds from there. And in fact, we later heard feedback from that client that they said, I don't know what Emily did, but it completely changed the trajectory of how people were referring to me throughout my hospital stay. So really powerful stuff kind of encompassed in these bubbles of what Emily's day-to-day looks like. So over to Ingrid for our preliminary insights into what being present looks like, though, as mentioned, we're digging much more into this.
Thank you very much, Allie, for that beautiful overview of some of the key insights so far. And as noted, this being present has literally over the past few weeks become something that we are very, very interested to further explore because, as you can imagine, upon first glance, it's a pretty big concept. And it's one that has a lot of relevance for nursing, for how we engage with people, for what is it about how we are with somebody that creates a sense of safety where people feel respected or they feel comfortable. So these were some of the key elements of this idea of presence that people talked about. So active listening and engagement with the client's full life, not just the hospital stay. So, this capacity of Emily to really recognize and perceive this person as a human being that exists in a variety of ways that's outside of simply this one encounter within a healthcare setting, which was very validating for people and made them feel very safe, made them feel like people. The non-judgmental, calm presence throughout the interaction, patient shared information with the liaison nurse that was not shared with the staff on the unit. And that is very indicative of this sense of safety and comfort. And we know how important it is to have salient information about what this person might be experiencing in their lives. There's info that's so valuable for us as health providers to have in order to meaningfully support them through whatever situation it is that they are in this health setting for. So having somebody in a role where they're able to elicit that information, a person is willing to share that, we know how powerful that is for health outcomes, potentially. Another piece was through leading by example. The liaison nurse is helping to promote safe and inclusive practices among staff. As Allie alluded to just a moment ago, these more innocuous and anecdotal exemplars, like we have some explicit, but we also know that there is a lot of implicit that Emily is doing by simply being in the unit, on the unit, and engaging with other health professionals. And in a very supportive way, offering up some information about how you might want to approach a situation, why it's important to honor somebody's pronouns, simple things that for some people might seem very, very obvious, but for others, having this information or having this sort of subtle support around, hey, here's a way you might want to do this, has massive implications for somebody's experience when they're in the health setting. And the last one, I think I went through them all. Thank you. So this is an exemplar for more of a case study situation that really highlights this idea of being present. And I'll just read through this. But one of the most emotional and touching moments from today's observations was the liaison nurse's interaction with an older, so 60+ palliative patient who had only begun transitioning 2 years prior. This patient, who was unaware of their poor prognosis, expressed concerns about their identity being respected during physical care and their inability to proceed with the top surgery they had hoped for. The liaison nurse was able to provide calming conversation to this patient, while knowing from their medical notes that this patient was not likely to live much longer. The liaison nurse's interaction with the palliative patient highlights her ability to address both physical and emotional concerns during complex end-of-life care. By acknowledging and discussing the patient's identity and providing a respectful, affirming presence during a vulnerable time, the liaison nurse ensured the patient felt seen and supported. She also liaised between the patient and broader healthcare team, including providing education for staff on best practices for supporting the need of transgender patients. So within this example, there are multiple layers of really important support that Emily was able to provide, from simply being present and offering that emotional support for the person to really advocating and liaising with the essential invested people to ensure that all of the things that could be made possible for this person to have the best experience within the confines of this particular scenario were made available. And that requires a broad skill set, but also I think that there is that magic and something that is difficult to capture, which is why the observations are so powerful about what it means to be with a person in a situation like this. What is it about that interaction that creates this environment of feeling safe, feeling heard, and feeling comfortable. Another example that we have from case study is one experience that stood out that involved a teenage non-binary patient admitted to hospital after a suicide attempt. For instance, during a visit with this patient in the psychiatric intensive care, they were initially withdrawn, reluctant to eat, and hesitant to engage with staff. The patient opened up to the liaison nurse about their trauma related to seclusion rooms and the challenging transition from pediatric to adult psychiatric care. The patient told the liaison nurse about their plan to stop eating so they could be transferred to a medical floor. She responded evenly and without any sense of judgment. While being mindful of this patient's history of disordered eating, the liaison nurse was able to help fill out their diet form to ensure meals included safe foods for them. This simple yet powerful act led to the patient visibly relaxing and engaging in a way they previously hadn't with other staff, speaking in full sentences rather than one-word replies. So again, just a testament to being with somebody in a way that has the capacity to entirely shift the energy of an interaction, such that the person feels safe and is willing to disclose important information, and that there was a space that was made available for Emily to engage in a way that was essential for ensuring that this person would have, again, a better experience than they likely would have had they not interacted with Emily.
Thanks so much, Ingrid. And I know who's in the room. And so I know that through these examples, we all are seeing the structural inequities that are shaping these people's experiences and the impacts of those structural inequities. And so I feel like though, we often find it hard to articulate what quote unquote nursing care looks like. This really goes to show that what Emily's role is doing, among many other things, is equity promoting care, and why it's so important to have dedicated roles that are directly embedded in the healthcare system with that aim of redressing inequities. Emily does a lot of direct client care, but we also just wanted to speak to the magnitude of things that occur within this role beyond client care alone. So 86% of days that Emily has logged so far do involve direct client encounters. And of course, that's a large magnitude of what the role is responsible for every day. But there's many other pieces as well that are encompassed in this role, which shows how important it is and how challenging it can be that right now in the province, there is one person in this role. So while there's kind of quote unquote at the bedside advocacy, there's also this sort of larger system level advocacy that the current liaison nurse, Emily, has undertaken across 12 days out of 37. So quite a magnitude there. We also see this healthcare provider education. So this is often more formal. It might look like some of these education sessions, or maybe coming to a kind of nursing huddle and giving a little bit of information, all of the different activities wrapped up in that. Some of the liaison nurses' own professional development. I mean, among many other things, the 2SLGBTQIA plus acronym is a large acronym, and any one person always has room to kind of grow into what it looks like to provide really positive, safe, and affirming care across the full spectrum of the acronym, not to mention things like life stage and all of the other kind of intersecting considerations. So ongoing professional development work is always kind of a crucial part of what it looks like to do these roles in a good way. Policy work is a huge piece. I know that across health authorities, there's more and more work toward developing, whether it's gender affirming policy or kind of safe and inclusive spaces policies. So this is a dedicated role that can really provide that kind of expert knowledge around some of this policy work. And then lastly, some community work. So engaging directly with communities kind of outside the hospital setting where the liaison nurse role is currently situated. Huge range of what it looks like to embody this role, certainly, and we will continue to explore this as we go throughout the remainder of our research. One thing that we also captured, and we're kind of ending on, is how greatly it is needed for there to be more than one Emily. And we always say we can't clone Emily, and nor maybe do we need 10 Emilys, but we need a huge diversity of people who are embodying roles like this. And so these are just numbers, and we'll speak a little bit to what that scale up would look like. But the numbers paint such a stark picture of how necessary this role is and how much it is needed, not only in greater numbers within Island Health, but clearly beyond, because we're only capturing 37 days worth of the healthcare system's everyday workings, but extrapolating this beyond, there's such a need. So in 37 days, there were a total of 186 client encounters that the current liaison nurse was not able to fulfill. This includes 104 referrals in 37 days that were missed because the individual, for example, maybe came into emergency and left again by the time Emily was able to see them because of all the other million things that she's doing in a day, as the data has kind of painted a picture of. In addition to that, there were 43 times when people who Emily wanted to engage with, she was unable to see because of just the magnitude of her work. So these were times where she hadn't yet met the person and was trying to engage, but the days get so full that she was not able to engage. In addition to that, there were 39 times where clients of hers who she'd already met, she'd intended to follow up and were unable to follow up because of, again, the magnitude of her work. So taking all of that together, these different kind of dimensions of what a missed encounter might look like, there's such a need for scaling up this role because there's real people out there who are in our healthcare system who are not being captured, not only within the one place that Emily works, but we know from so much wonderful research that's come before us and from just kind of all of our knowledge of the healthcare system that there's people across all health settings who could so benefit from this role. What we in our small little world are doing about this is we have been on quite a listening tour of many, many people in all kinds of different roles in health leadership, health systems, at the BCNU, in community organizations. And what we are working toward is actively scaling up this role in other health settings in BC. There's already work underway within Island Health to establish a second position, which we're really hopeful will materialize soon. And then we're also in conversations with a variety of other hospitals and programs across a few different BC health authorities to establish either similar or identical, pretty much, roles. There's a job description that has been filed with HEABC, which really lays some crucial groundwork for what it would look like to continue to put in place a similar role in other health settings. And then, as always, we are ready on the research end to look at what this will look like to be kind of tailored and modified across sites, because the snapshot that we showed you today is really contextual in so many ways. It's contextual to the health setting where Emily works right now, which is Royal Jubilee Hospital. It will look very different at Victoria General and across any program or hospital that it gets kind of implemented. And it also is so particular to the person as well. You know, we all bring our own selves to nursing, even if we have a job description. And so what one person does in this role will look so different. And this data is really reflective of that person as well. So we're putting in a large CHR grant to see what we can do about researching this scale up that we are working toward. So we will come back at you in 5 years, hopefully, with some additional great data. And we're really lucky to have some wonderful UBC folks on that team, including Vicky Bungie and Trevor Goodyear. So thank you so much for all of your contributions, as well as some people from other universities. But that's a little snapshot of where we're at. So we hope that, again, in this little way, we are helping respond to this need for scale up, and we will see what it looks like when this role is embedded, we hope, not only across BC health authorities, but ultimately beyond, because I really think this has a place across Canada in our health settings, especially in our current political climate. So that's all from us. Thank you so much for listening. I will stop sharing, and I think we may have some time for questions or comments.
Thank you both. That was amazing and very interesting, and I can't wait to follow this along and hear more and more about the results that are coming out of this. Obviously, such a needed role, and as we all know, the evidence is critical for being able to support any kind of policy decisions around things like this. So. I'm going to monitor the chat for questions, but I know there's a lot of people that are going to be raising their hands and asking questions on the screen. So we'll start with those, and then I'll jump in if anybody's writing questions into the chat. So, oh, questions. Elizabeth.
I think Sally had her hand up first, so
I wasn't looking. Sorry, I was already looking over at the chat. See, I've already messed up on my question
I'll defer
management.
to Sally as the first question.
Oh, I loved it, Allie and Ingrid. It's fantastic to hear it and the excitement that you have about this. And the question I have is a little bit sort of counter to the support of the thing. It's more that large worry in the equity world of what happens if we take the navigation track down its final line. And we've identified certain communities such as this, which I fully understand why it needs liaison and specialization. But the more we identify certain communities that have one, and the more we institute them into our systems, what happens to the rest of our systems with regard to equity work? So I wonder, in the context of doing this, and not to discourage anything that you're doing with regard to getting CHR funding to take it further, but is there also a side of your brain that can be thinking about that larger context of how we create, how we build these kinds of projects into systems that no longer need special navigators?
Yes. Thank you so much, Sally. We say every day that we hope Emily works herself out of a job. It's not Emily alone. We are not putting the burden of all this work on her shoulders, but we hope we all work ourselves out of a job in a way, right? But this is exactly the tension, it's so interesting. And there's so many amazing scholars at UBC and UVic and elsewhere who are doing this really big picture equity work that is so needed in systems. And while we've been on this kind of talking tour, we have had the pleasure of engaging with so many people within the healthcare systems who are doing absolutely incredible work. We spoke to someone a few weeks ago who created an entire kind of 2SLGBTQIA affirming plan for the healthcare system that included policy and all of these other things. And so there's so much amazing work happening, and it's certainly a multi-pronged effort. It's so interesting to think of where these navigator kind of liaising roles come in, because it's so, I think all of us, it's so obvious that they are, Band-Aid sounds harsh, but they are a response to a deeply inequitable system. And we're kind of saying like, oh, maybe we'll just stick a person in there and they'll do their best. And honestly, it's really hard on the person because they are in this milieu and it's not always the equitable system we'd like to see. And so it really does speak to the need for that multi-pronged effort. What's so interesting about this to me is that also in among all of the system stuff, it was a grassroots effort that was able to come into being in a shockingly short time frame because it leveraged a need and an opportunity. And there's something really powerful about that too. I think as we're thinking so big picture, and we need to, there's also an immense ability to leverage really local resources to do this kind of thing. And we're finding that sometimes we have, these huge conversations about, oh, what if we could establish XYZ resources to do this at the provincial level? And sometimes that doesn't get as far as saying to an emergency department director who's a nurse, hey, could you use one of your vacant lines to do this? And they go, oh, sure, that seems really reasonable. So sometimes these little things have a kind of movability that creates something now that I think then builds a momentum within health authorities that can drive toward that systems level work, because there's a person who's advocating every day, and there's just that visibilized commitment to, we think this area of moving equity forward is important, and so we're going to build from the resources we have just greater and greater and greater and higher up at the systems level. That's just a preliminary thought from me. Ingrid, do you want to chime in?
Yes, we had some wonderful conversations in this vein, Sally. We were fortunate to get some funding through Michael Smith and for a C2. So we were able to convene and collaborate in Vancouver. It was mid-month. I don't even have a sense of time anymore, but in January with health authority leaders, with community organization representatives, with other folks from the community, and with the research team, and with Emily. And we had some really fulsome conversations about the nature of navigation, about you bring in a role, how is it sustainable? Maybe it stays for a bit, then it drops off. Like, what is the bigger picture for these kinds of initiatives, and how do we really make a difference that's long-standing? We had some wonderful conversations about kind of going on the coattails of what you were saying, Allie, about momentum and like garnering this energy and sustaining it through really embodying. And it's not, we had this great conversation about it's not asking people to do more work. So you have somebody present that's in this incredible role, but what you're really looking to do is establish an environment of champions. You're really looking to imbue within this unit or within this entire health authority this commitment to doing this work that is literally embedded within the very nature of what you do. We as nurses know, like, that ought to be our focus. So when we have somebody come in a specific role that's explicitly doing that, that really offers up this powerful exemplar of small shifts that we can do within our own work. And if we collectively establish this dynamic within a unit where folks are geared and they're oriented in a particular way, and they're doing this work as an essence or component of their very way of being, it's not work off the side of my desk. It's not extra. It is literally how you do your work. Once that is instilled, the power for that to now set a precedent for how we do the work, for me, is what we're really seeking to do. And it isn't to suggest, as you used a very powerful metaphor, Allie, about the Band-Aid, but like, we're really in a situation where we need this now. So bring it in, and it now sets a precedent. So perhaps the role in and of itself, Emily will work herself out of a role. Wouldn't that be amazing? Right? Because the dynamic that Emily's example sets for how it shifts the entire milieu in that unit, on that floor, on that whole wing of a hospital, and then just as a delightful, what's the word I'm looking for? It's like osmosis, but greater, because we're not just talking about water, it moves outward, right? And then this is literally how people exist within the system, tuned to these things. So that's kind of my very potentially naively optimistic hope. But what happens when you have times are really hard right now. Like, I'm not going to mince words here. It is a tough situation. I'm feeling the heaviness of the societal dynamic that we find ourselves in. And it feels really hard sometimes to stay hopeful and to keep pushing and to say, are you kidding me? Like, this is something we have to, anyway, that's a different conversation. But this is now embedded within this overarching dynamic, which is really hard. So if we can establish this type of a dynamic within health authorities by bringing in this role, and we shift things, that's kind of my vision for the future of this work, and how then it has that sustainability, because everybody is just now oriented in this way. And I know that's a bit much, but I do think that's ultimately what we're seeking to do. Is that's what I have to say about that. But we had such wonderful conversations and input around the power that has, and how we can really thoughtfully embed these within broader dynamics, and the power that they have to shift how people do things. So that's what I have to say about that. Thank you. Wonderful question.
Elizabeth.
Okay. You've already somewhat alluded to one of the two questions I was going to bring up. So I'll bring up the research-focused one first. And that is, have you, in the process of looking at sort of the feasibility and the different types of data that you're collecting, have you given some thought to capturing impact from a financial standpoint?
Oh, yes. It's yes. I don't know whether to say unfortunately or not. We have. I must confess, it is not the strong suit of myself nor Ingrid. I'm sorry to put you out there, Ingrid. I'm just going to say it. But it's so important. It's so important. I mean, it's the reality. It's the reality we live in, and this is the healthcare system context. Is everything has to come back to this right now. And I think that there's so many ways to make the quote unquote case for the liaison nurse, which sometimes it feels like that's our job, even though we're doing this sort of research paradigm, but that also we're trying to establish something. And we've had a lot of conversations about what that intersection looks like, to be researching something while kind of advocating for its scale up. That's a separate question. But in that, how we advocate for it, how we situate it, how we quote unquote make the case, there's such a financial piece. And I think all of us intuitively sense and know that it will be greatly cost savings, because one of our biggest questions out of this is, will it enhance people's willingness to seek care in the future? And so we suspect yes, because the research shows us that discrimination and inequities is one of the leading causes of people from this community not seeking care. And then we know the health outcomes associated with that. So then if people are more willing to seek care, therefore treat symptoms earlier, all of this stuff, I'm preaching to the choir here, but we know we'll have great cost savings well above somebody's salary. That said, there's so many directions to go with this research, because we just happen to hop on the bandwagon and be graciously invited in to something that is quite new, I will say, though it's so situated in kind of other health system initiatives already, but new in this exact iteration. And so we are getting the program of research rolling here with a community engaged mixed methods study of what it looks like to tailor and situate the role and really fulsomely understand the role. From there, our goal is to move in a much more kind of dedicated way to impacts. And I think that will need to have a cost piece, though we will certainly be soliciting expertise of those who are more familiar with cost feasibility studies. So great question. Ingrid, do you want to throw in anything before Elizabeth? Maybe you have a follow-up kind of comment to this about how you think we could leverage that type of inquiry.
I can say a couple of quick things just in light of your delightful response, which again, so many conversations that we were able to have last month that brought forth a lot of these kinds of things. And a big one we had, Elizabeth, unsurprisingly, was the money card. Okay. Do you want to more explicitly play the money card? And I think, as Allie, how you've beautifully articulated that, like, we are really just like in the emerging phases of this, and from this one idea have carved out so many angles through which we must explore this role. And certainly, once I think for us right now in this moment, the biggest question we have is to really understand, like, to really just verbatim, like, how the role is conceptualized, practiced, and experienced. Like, we just need to get a grasp on that. And from there, certainly we have been encouraged, and we, despite our own perhaps reluctance, to delve into the world of implementation science. But certainly there is a role and a need to potentially, I think, very really walk that road and look at the implementation piece, for which certainly that fiscal component will be so much more explicit. And I think we will, in understanding the role much better, will then be able to fully kind of conceptualize how to meaningfully like integrate the financial component in a way that will be really effective. So I feel like you and I, Allie, are just in this like whirlwind of figuring things out in this moment and slowly getting there, and with the grateful support of this incredible team of people we get to work with. But it's been a lot, and it's all happened very fast. That's part of it's been like breakneck speed for all folks here. Can imagine to have a role implemented like up and running so quickly. We've really had to kind of go backwards and say, well, what are we actually doing here? Like, we know you know what you're doing, but now we need to really kind of construct this in a way that's like really tangible for people across, a variety of settings to be like, yes, because we always get that question. What does a person do? And we're like, okay, we are so embedded in this that we know what's going on. We really need to get tactical about how we describe this. So first we need to really collect the data so that we can fulsomely explain, this is what's going on with the role. This is what it is. This is what it does. These are the people that are supported. And I think now that we are getting there, that we can like embark on these more like really strategic approaches of, all right, so now we're going to show you how it's going to save you lots of money, because we all know that gets the attention of a lot of people.
Money isn't the only thing, and obviously quality of care and quality of life,
it seems like everything these days, though, doesn't it?
That are good and important too. But definitely that is one of those things that some of the decision makers who might not be moved by it's the right thing to do, or might not be particularly enthralled about human rights, or they seem to really do focus on the cost savings or the cost benefits or what have you. It does remind me of a project I did, oh God, a long time ago now. Actually trying to make visible what public health nurses in the North Van Child and Youth Unit actually did, using our sort of wheel of intervention, sort of, okay, this portion of what they're doing is advocacy, this is outreach, this is education, this is facilitation or coalition building, et cetera, et cetera. Like, and getting the unit to actually capture the, I just did, so that you're not saying, oh, I just went to a meeting, or I just like saw the patient and didn't do anything, like, oh, I just talked to the patient, and actually capture a little more of what they were doing in a way that could both speak to the reach, how many people they touched, and what the full scope of what they were doing was, but also that created an opportunity to then start looking at where they had been previously thinking about reducing the services, being able to show like where they all, what was actually happening, and the potential that contributed to better referral systems or reduced challenges along the way, but also great, you see someone who's actually responding to care and therefore not trying to shift out of the psychiatric unit into a medical unit with further expenses that go with that. Seeing people actually engaging care, maybe being able to leave the unit earlier than they might otherwise, or not have as many repeat hospitalizations or such. These are all things to maybe be thinking about down the road, and when you've got a large enough, potentially one or more additional people doing this work in other places, to be able to identify and then compare across units. I think it's really exciting. And the sort of navigator liaison champion role is one that there is, increasingly useful evidence around, and I'm just so thrilled.
Well, thank you, both you, Allie and Ingrid, and everybody who joined us, and the questions and the great conversation. This is obviously something we could talk for another hour about and engage around, and longer than an hour, I'm sure. But it's great to have this conversation. We're all looking forward to the ongoing research.